Good evening. Thanks for joining us tonight. I'm Dr. Matthew Gordon. I am a fellowship trained orthopedic surgeon. I trained in sports medicine and minimally invasive surgery. I work at Crystal Run Healthcare, and I am also affiliated with St. Luke's Hospital. A little bit about me. It's my background, so you know who I am. I did my medical school at SUNY Upstate in Syracuse, New York. I did then a residency at SUNY Downstate, which is in Brooklyn, New York. I did an orthopedic sports medicine fellowship out in Cincinnati, Ohio. I have a little map of it there. And then I've been at Crystal Run Healthcare here in Newburgh for about 5.5 years. I was in practice in Connecticut before that. And currently I'm affiliated with Montefiore St. Luke's Cornwall Hospital. I get the whole thing in there. A little bit brief legal stuff. As I put there, this presentation is only for informational purposes. It's not meant to help you treat, diagnose, or prevent any condition, any medical condition. I'm going to provide an overview of common shoulder conditions. If you have any specific questions, please direct them to a doctor. Really nothing does substitute for a formal medical evaluation. Overview, we're going to go over some of the basic anatomy of the shoulder and how the function of the shoulder makes certain conditions more common. We're going to review some common shoulder conditions. Prevention of shoulder injuries, and review general treatment options. And then finally, at the end, we're going to have some questions. I ask that if you could type them in the little question box, we'll review them at the end and go through them. So the shoulder anatomy and function, the shoulder is really actually 3 joints. It's called a joint complex. There's the actual ball and socket joint, which is what most people think of as the shoulder joint. The ball is on what's called the humerus, which is the arm bone. So you guys can see the pointer here. So this bone right here is the humerus. The socket is part of what's called the scapula, or the shoulder blade. And then there is a joint where the collarbone and the shoulder blade meet one another. And point out that the shoulder blade is sitting on the chest wall. It's a very mobile joint. You can move your arm in a tremendous amount of positions, but as a result, it's also incredibly unstable. You have a large ball and a very small and flat socket. The rotator cuff, that's the sort of the star of the show, if you will, is 4 tendons and muscles, which attach around the top of the arm bone. You can see that in this bottom picture here. So there's one in the front, one in the top, and there's 2 around the back, which you don't really see as well here. And they help stabilize the shoulder joint. The bursa, which is a lubricating membrane that sits between the tendons and the bottom of the shoulder blade. The labrum, which we'll show in a different slide here, but that basically surrounds the socket and helps stabilize the shoulder joint. Numerous surrounding muscles around the shoulder blade and around the arm bone itself, and then the biceps tendon, which is this right here. So some common shoulder conditions. So the basic thing is a shoulder strain or sprain. These are essentially all due to injury. They result from excessive pull on the arm. They can involve the rotator cuff tendons and muscles, the shoulder capsule, which is the soft tissues that actually hold the shoulder joint intact, the trapezius, which is the muscle basically on the top over here that kind of runs down to the shoulder blade and actually runs all the way down to the mid back. That's a picture of it right there. And then the other muscles around the shoulder blade. And any of these can get pulled beyond the point where it wants to. Common treatment is with heat and or ice to help with the immediate pain, anti-inflammatory medications and or Tylenol, and physical therapy. So we'll launch into rotator cuff tendonitis and bursitis. So as I said, the rotator cuff tendons are sitting here, and then the bursa is sitting right above that. When you use your arm, your ball moves around your socket, those rotator cuff tendons are working overtime, and sometimes they get a bit fatigued, they get a bit tired. And when they do, they kind of pinch into the bottom of the shoulder blade here and they get inflamed, which makes them function less well. As a result of that, they start to hurt, and then it puts your shoulder at risk of further injury. Tendonitis, bursitis can generally be diagnosed on exam and history, assuming there's a negative x-ray. And the treatment initially involves ice, anti-inflammatory medications, physical therapy, and cortisone injections. Don't worry, we do not have a cortisone injection or a needle of that size. That's much bigger than normal. Calcific tendonitis is a unique or a special type of tendonitis. It results from a calcium deposit. You can see in this upper picture here in the x-ray, that large thing there is not supposed to be there. So you get this large calcium deposit that forms in the tendon. Sometimes it's due to a sort of a minor trauma. The symptoms of this are very quick onset of severe pain, type of pain that will bring you to tears. X-ray is very helpful in diagnosing this, as we see in that picture there. You can see that large calcium deposit. A cortisone injection, certainly as an initial treatment, is recommended. This generally responds very favorably and very quickly to a cortisone injection. Icing is helpful as well. Anti-inflammatories are also helpful. And then surgery, this is a picture from surgery, is only if it's refractory. And that's the large calcium deposit there being taken out of the tendon. Shoulder impingement, as I said, the shoulder joint mechanics put it at risk of being injured. You have that big ball and small flat socket. And when you raise your arm up, like this is showing here, that tendon gets pinched, and the bursa also gets pinched into the bottom of the shoulder blade here, and that can irritate it. It can either cause inflammation, which is, I guess, if you're lucky, or a tear with further injury to it. Again, the symptom of this is really pain with elevation when that tendon and that bursa are getting pinched into the shoulder blade. Because it's primarily a mechanical problem, physical therapy, certainly at the initial stages, is very helpful. Again, icing, anti-inflammatories, and possibly a cortisone injection if there's a tremendous amount of inflammation. Surgery is only used when it's either not getting better from extensive conservative treatment, or if there is a tear present. So talk about rotator cuff tears now. As I said, many of these occur without any sort of specific injury. Sometimes they do occur from a fall or getting your arm jammed up, or something pulling on the arm, but in general, these are due to wear and tear. The tendon tissue has a certain amount of cycles, and if they're getting irritated, then it bothers it. The symptoms of a rotator cuff tear generally involve weakness in the arm. There is some pain present, but usually they're not as painful as when there's bursitis or inflammation present. History and physical exam are important to diagnose, and then an MRI is used to confirm it. So this little schematic here, this is the top of the arm bone here. This is the top rotator cuff muscle. This is the tendon right here, and you can clearly see that it's torn off the bone right here. And then this is an MRI of it. So the socket is right here. The ball is right here. The tendon and muscle are running over the top. And then thankfully they put an arrow here. Right here is where the tear is. So treatment of rotator cuff tears really depends upon the size of the tear and then the functional needs of the arm. So a complete tear or an incomplete tear is really one of the key things we're looking for. So that's where an MRI is helpful. You look up here, this is a sort of a normal portion of the tendon. There's no tear right there. This is what we call like high-grade partial tear. So it's almost completely torn through, and this whitish area is fluid entering into where the tendon should be. If it's less than half of the tendon thickness, so looking at it like this, then no surgery is generally needed. If it's more than half, then surgery generally is needed. Chronic tears, where the tear has been there for a long time, sometimes this requires just physical therapy to help improve the function of the arm, and then also in other cases, shoulder replacement may be necessary. We'll talk about that a little bit more later. Generally, when we're talking about surgery, we're talking about an arthroscopic surgery. It's done in a minimally invasive manner, anywhere from 3 to 5 holes around the shoulder typically. And then we use a special camera and special instruments to go in and actually tack the tendon down and allow it to heal in place. Shoulder instability. So this is we'll call a spectrum of disease. It can be anything from subluxation episodes where the shoulder only comes part of the way out, it's not coming completely out, and an actual dislocation where the shoulder comes all the way out of socket. In some, but not all cases, this is not related to an injury. Some people just have inherently loose joints, and then also the shoulder blade and the socket don't move in sync. So when the shoulder is moving, about approximately a third of the motion comes from the shoulder blade moving on the chest wall. And then 2/3, the remainder, or the larger portion of it, comes from the ball moving on the socket. So if those are mismatched, then the shoulder can come out or partially come out. Physical therapy is generally helpful for those cases where it's not injury related. Shoulder dislocations, these are usually due to trauma, although as I said, there are some people because of their because of the function of their arm or because they have kind of looser joints will be able to dislocate their shoulder relatively easily. If there is a shoulder dislocation, it needs to be promptly reduced. Some people will be able to do it on their own actually, but in general, it's better to go to the ER and have them reduce it for you. This is one of the few conditions where in medicine, it's better to actually be older when you have your first injury. In general, most things, the younger you are, the better they heal, but older people tend to not dislocate again if they have a dislocation. The only caveat to that is people over the age of 65 can often have a rotator cuff tear associated with a dislocation. So that it's important to get that diagnosed as well. If left untreated or if there are recurrent dislocations, meaning multiple dislocations, then arthritis can occur. So labral tears, these are generally related to injury after a dislocation. Typically, this is kind of a side view of the shoulder here. This is the labrum surrounding it, and this reddish area is showing where the dislocation is. So the shoulder, the ball kind of comes out down into the front and typically, and to the bottom, and it causes a tear in the labrum. The labrum, again, is that bumper of tissue around the shoulder socket. Some labral tears are due to repetitive use, so they're not specifically injury-related. The typical symptoms of a labral tear are pain, obviously, a sense of instability in the shoulder, and then a clicking or a clunking sensation on motion of the shoulder. And we use a special type of MRI to help diagnose these. It's called an MR arthrogram, in which a dye is injected into the shoulder joint, which is this whitish stuff here. And then the MRI is performed. So this is showing the labral tear off the front of the labrum that kind of blacked out right there. That's supposed to be over here on the front of the socket. And then this is a picture from the surgery. This is the ball. This is the socket. This is the labrum right here, and right there is where the tear is. Slap tears, this is a specific type of a tear of the labrum. This is at where the bicep tendon, and that's this right here, attaches right onto the top of the socket onto the labrum. This is typically found in throwing athletes. Think of a baseball pitcher or a javelin thrower, but they can occur from injury, specific injury as well. These may require surgery in athletes. This is a picture of it. It's a tear right there. That's the bicep attachment. And this is a picture after repair. So those are the sutures holding the labrum in place, and the bicep is right there. And treatment, again, depends on the functional needs of the arm. As I said, in athletes, this will be treated with surgery with a repair. In some people, we actually just cut the tendon and then tack it down further on down into the bone, and that usually will take care of the problem. So bicep tendonitis, this again involves the bicep tendon where it goes into the shoulder joint. So there's really called two heads of the bicep. The bicep has two parts to it. So the front part attaches right there, and what's called the long head, which is this one, comes around and it attaches onto the top of the shoulder socket, which we were just seeing on the previous slide. And this generally results in pain over the front of the shoulder and radiating into the bicep. Treatment is typically with ice, physical therapy, anti-inflammatories, and then an occasional cortisone injection. And then surgery only if it's refractory. Again, we typically will cut the tendon and then tack it into the bone roughly about there, roughly into the front of the arm bone. Shoulder arthritis. So this is much less common than knee or hip arthritis. Again, the shoulder is a non-weight bearing joint. As a result of that, it's generally tolerated for longer. There's two types of arthritis that we talk about in the shoulder typically. There's arthritis due to wear and tear and or injury, and then there's arthritis due to rotator cuff tears. Non-operative treatment options include anti-inflammatories, physical therapy, activity modifications, and cortisone injections. And then for shoulder osteoarthritis, so this is the one that's generally due to progressive wear and tear of the joint surfaces, also can be done due to, again, repetitive dislocations or other injury to it. It's common in heavy laborers and weightlifters. There are other athletes, anyone who's using their arms a lot in a way that's not typical of the way we use our arms. Those people can get arthritis. The symptoms of arthritis are what you'd imagine. There's a lot of pain, there's stiffness, and limitation of range of motion. If it's not getting better without surgery, there is a surgical option which involves a total shoulder replacement, which this is a picture of it here. So basically there's a stem that goes into the bone. So basically this part of the bone is cut off, the stem goes into the bone. There's a ball that replaces it, and then a little bit hard to see over, there's a plastic button that goes on the socket side, and that's actually a little post bit that's holding it in place right there. The key thing to a standard total shoulder replacement is that you need an intact rotator cuff. You're trying to reproduce the normal mechanics of the shoulder, and that only works when the tendons of the rotator cuff are intact. Next type of arthritis is what we call rotator cuff tear arthropathy. It results from large chronic rotator cuff tears, generally seen in an older population due to failure of the rotator cuff. And sorry, this is a picture of it here. So you can see this is the ball, this is the socket, and that's not lined up. That's roughly the center of the ball, and that's the center of the socket. You can see they're clearly not lined up. And what happens is eventually the ball hits into the bottom of it's called the acromion, which is this part of the shoulder blade right here. It makes it difficult to lift the arm up. As a result, it becomes painful and you lose function of the arm. The surgical option for this is what's called a reverse shoulder replacement. Again, the ball, this is a flipping of the ball in the socket. The ball is placed in the socket, and then a stem is placed into the arm bone, and then there's a plastic bearing that goes in between. And this allows the deltoid, which is the outer muscle, you kind of see the shadow up here, that attaches all the way down the arm bone here to be the primary elevator. Fractures, typically it involves the ball over here, called proximal humerus fractures. These are generally treated without surgery. 90+% of the time they're non-surgical. Surgery is only when they're significantly displaced. And this is a picture of surgery performed here where a plate and screws are put to help hold it in place and realign it. And in general, so when they're not treated non-surgically, a sling is used to help hold the arm to protect it while it's healing. And then physical therapy as it starts to heal to prevent the shoulder from getting stale. Other fractures involve the shoulder blade. These are fairly uncommon, thankfully. And then collarbone fractures, which are sort of in the middle. This is a picture of one here. Finally, what I've included in my shoulder pain talk is a talk about neck pain. So this is actually a common cause of shoulder pain. A lot of times you see people come into the office and they have pain in their shoulder. So I said there's an overlap of the two. Shoulder pain can sometimes present with pain in the neck, and then neck pain can sometimes present with pain into the shoulder. And that's because the muscles of the shoulder blade or the neck, the muscles that attach to the neck also attach to the shoulder blade. So the trapezius muscles, the rhomboids, and some other muscles down here that also attach, and that causes a lot of overlap in the symptoms. Arthritis in the neck can also be felt into the shoulder region, and then pinched nerves in the neck can also be felt in the shoulder region. An evaluation by a doctor will help to distinguish between the two. And finally, what I want to talk about is prevention of shoulder injury. So some of this probably is common sense, or hopefully it's common sense. Use good mechanics while exercising. Use proper form. Give appropriate rest intervals. So don't do the same thing day after day after day. Gradually increase your activity. So don't decide that you're going to be He-Man right away. Just do a slow progression of activities. And then more for athletes, so we tend to see it a lot, particularly in kids now, unfortunately. They do one sport all the time, one activity all the time. They take they're on 3 different teams and they're constantly doing that activity, that sets you up to have injuries in whatever body part, but in this case, we're talking about the shoulder. And this last one, if it hurts a lot, stop. A little pain is okay. It's normal to have some pain during exercise, but a lot of pain, that's generally an indication that there's something going on and that you should probably stop. And if it doesn't get better with a little bit of time, then you should get it checked out. So in summary, the shoulder is a complex joint. The anatomy of the shoulder makes it vulnerable to a number of issues, some due to injury and some due to overuse. Many shoulder issues, most shoulder issues actually can be treated without surgery. However, if surgery does become necessary, there are some minimally invasive surgical options available, depends obviously on the condition. And that can be determined by getting an evaluation. So thank you.